everyone, and thank you for joining us. We're delighted that you could be here today for this teleconference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Casey Minnis, Director of Communications for MS Focus, and I'm joined by Herb Karpatkin, who will be talking to us about science-based approaches to exercise. After the presentation, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Dr. Herb Karpatkin has been a practicing physical therapist for over 30 years. He received his master's degree in physical therapy from Boston University and a doctorate in neurology from Rocky Mountain University. He's board certified in both neurologic physical therapy and in multiple sclerosis. He's held clinical posts at the Rusk Institute of Rehabilitation Medicine, Burke Rehabilitation Hospital, the International Multiple Sclerosis Management Practice, and is currently an associate professor of physical therapy at Hunter College. He's presented nationally and published extensively on topics related to physical therapy and MS. He's also the owner of a physical therapy practice specializing in treating persons with MS. We're pleased to have him join us and present this important topic. Dr. Karpatkin, thank you for being with us, and I'll turn it over to you.
Thank you so much, Casey. I'm really very grateful to the MS Foundation for asking me to come and give this talk. As Casey just said, I have been a physical therapist since the 80s, and I've been specializing in MS since the 90s. I'm a physical therapist by training. I still see patients. I literally just came from a patient before giving this talk. But over the years, I've become a researcher. And the topic of my research is exercise and multiple sclerosis. And when I was offered the opportunity by the MS Foundation to give this talk on this topic, I was very excited to do so because science is important. Science is what lets you know whether an approach to exercise is appropriate or not. So what I'm going to do in these slides today is try to give you a very, very brief training on what we mean by a science-based approach. I'm going to share with you some of the research that I and my team have done on multiple sclerosis and exercise. And then I'm going to open it up for questions, because when I give a talk for the MS Foundation, usually the Q&A, the question and answer period, is the best. So I'm just going to move ahead. Okay, so first, multiple sclerosis. Although your physician or researchers may think of MS as a disease of demyelination, a disease of inflammation of the nervous system, a disease of the blood-brain barrier, as a physical therapist, I think of MS as a disease of mobility. As a result of MS, you have trouble moving. The demyelination, it decreases your ability to walk, to balance, to move, to do the things that you want to do with your life. Now, a big change in MS since I've been practicing, 30 years ago, there really wasn't much by way of medication. Now there's a lot of medications that do a pretty good job of addressing and limiting the progression of the disease, but they do not restore lost movement. That's where I come in. That's where physical therapy comes in. If you have trouble with moving, walking, balancing, reaching, turning over in bed because of the MS, you shouldn't expect your disease-modifying therapy to fix that. You should expect physical therapy to fix that. If you've lost movement, how are you going to get it back? You practice that movement. But whenever I start giving this talk, people start thinking or start asking me right away, well, which movements should I do? Which exercise should I do? And then I invariably get this question, what's the best exercise for MS? And there's no best exercise for MS, in the same that there's no best medicine for MS. MS is a disease of tremendous variability. Persons can present in incredibly different ways from person to person. The same person can present differently from day to day, even from hour to hour. Each individual with MS has a different experience of having the MS, and therefore each person has a different experience of how their mobility has been affected. The exercise programs have to be specific to the individual's needs. I sometimes think for each new MS patient I see, I have to invent a whole new therapy for them. I'd like you all to think that exercise is like medicine. In the same way that a physician would use medicine to treat a disease, I use exercise to treat a disease. In the same way that medicine has an optimal dosage, an optimal intensity, optimal indications and contraindications, so does exercise. For exercise to be effective, you have to be doing the right exercise at the proper dose, at the right time, at the right intensity. It's not as if, you go to see a physical therapist and say, hey, give me a big bucket of exercise and I'll pour it all over myself. It doesn't work that way. Exercise has to be specific to the individual patient and the individual patient's needs. So how then do we determine what is the best exercise for each individual person with MS? The same way you determine the best of any type of care with science. Consider the following: the pharmaceuticals that are used to treat MS, the disease-modifying therapies, the Copaxone, Rebif, Avonex, Betaseron, Tisabri, Rituxan. These are all rigorously tested in laboratories and in epidemiologic studies for months to years before they're considered safe enough to use with patients. I think exercise should be held to a similar set of rules, that we can't just throw exercise at people and hope for the best. Exercise should be tested to see what is the best exercise for this individual person and what is not a good exercise for this individual person. So what do we mean by science? When people think of science, they think of hunched over little men in lab coats pouring things in and out of test tubes. No. Science refers to a way of answering a question, a systematic and empirical way of looking at a problem and trying to solve the problem. Okay, so here's the question that faces me pretty much every day of my professional life. How can we improve walking in persons with MS? Well, we know that persons with MS are affected by heat, and maybe the heat is affecting their walking. So then a scientist makes a hypothesis, which is really just a fancy way of saying an educated guess. If you cool persons with MS, it may improve their walking. And then we test that hypothesis with a scientific experiment. So we do an experiment, and this is an experiment that we actually just did, okay? And I'm going to give you the results in a moment. We look at the effects of cooling on walking in persons with MS. So one of two things is going to happen. We cool people off and they walk better cooled than uncooled, or they do not walk better cooled than uncooled. Based on the outcomes of the study, we can make decisions about how to exercise. If the study shows that people with MS, when they're cooled, they walk better in some way, that's proving the hypothesis. If they don't walk better, that's disproving the hypothesis. If they walk better, that means this is something we can recommend to our patients because science has showed it. So that is science. What is not science? Okay, this slide says what is science. What it really should say is what is not science. And this is stuff I hear all the time. So I ask somebody, why are you doing this exercise? That, well, my neighbor said I should give it a try, so I figured I'd give it a try. Okay. Or I saw a commercial for this and the person on the commercial looked pretty good, so I'm going to do that. Or this is what I see other people doing, so I figured I'd do it as well. Or sometimes they'll hear a therapist say, well, I don't know if this works, but I've always done this, so that's what I'm going to do it. Or I read a story about it somewhere, so I'm going to give it a try. That's not science. Those are called anecdotes. Anecdotes can be useful. They give ideas, but they're not science. And treatment for MS, I implore you, should be based on evidence and not on anecdotes. Lots of anecdotes is not science. Lots of anecdotes is simply lots of people talking. Science is a way of testing your hypothesis. So what does science tell us? What I'm going to do in the next 25 slides or so is try and give you a brief idea of what science tells us about exercise and MS. Now, I'm going to go back in time a little bit. In the 1980s, when I first started practicing physical therapy, a lot of the doctors I worked with said, no, do not do exercise with persons with MS. It will make them worse. It will lead to an exacerbation. And then there was some research done to test that hypothesis. The hypothesis was exercise will lead to exacerbations in MS. What happened? They gave persons with MS a fairly aggressive exercise program, and it did not make them worse. It did not lead to exacerbations, although it did lead to something called a pseudoexacerbation or a false exacerbation. What's that? A pseudoexacerbation is a transient worsening of symptoms that sometimes follows exercise. It gets better in anywhere from minutes to hours. Okay? It can occur following an activity that increases your core temperature, like exercise, or it can follow simply being in really hot weather for a while. It can follow having an infection, which raises your body temperature for a while. But the key thing about a pseudoexacerbation is that over time, it gets better. There's no change. There's no worsening of the disease. And when I was writing this presentation the other day, I remember a patient coming to me once, really upset with me, saying, you said exercise was good for me, but yesterday I went for a bike ride, and when I was done with it, I could hardly walk. Now, she rode about 30 miles in 90-degree weather, so I could understand why she didn't walk. I said, well, how are you feeling now? Oh, fine. So you didn't have an exacerbation. You had a pseudo-exacerbation. Now, this is probably old news to a lot of you who are listening, but it's worth noting that 25 years ago, this was not considered the state of the art of knowledge. It was considered pretty far out. So what else do we know? What is the impact of exercise on persons with MS? Well, it's the same as everybody else. Persons with MS, when they exercise, have the same type of exercise responses than that persons without MS have. If they exercise for fitness, to get aerobic fitness or improve strength, their strength will get better. If they exercise to improve function, their function will get better, same as everyone else. But what's also worth noting is some new research which has shown that when you compared persons with MS who exercised over a lifetime to those who did not exercise, who were sedentary over their lifetime, two things are found. First, the persons who exercised have overall less disability compared to non-exercisers. That the effect of the MS was less on them, less on the people who exercised than on the people who did not. But what's more interesting, or equally interesting, is when they did postmortem examinations on persons with MS who died and who gave their body to science afterwards, they compared their nervous system. And the persons who exercised over a lifetime had much healthier nervous systems. They had less disease activity in their brains and spinal cords than the persons who did not exercise. So exercise not only decreased disability, but probably did so by decreasing the amount of disease activity. There's something overall about exercise that is neuroprotective. Okay. What's the next big point I want to make about exercise? This has to do with a term that is very prominent in my field nowadays, and that is called neuroplasticity. What it means is your nervous system, your brain and your spinal cord change as a result of experience. This can also just be called learning. Here's the example I give when I speak to my students. Imagine somebody playing a guitar, but they've never played before in their lives. And then they're given 5 hours of lessons a day or 1,000 days in a row. The part of their brain which controlled guitar playing is going to get much larger than it was before. That change in the brain architecture is referred to as neuroplasticity. Literally, your neurons are plastic. They can change. Okay? And if you take the same person and they stop practicing guitar completely for another 1,000 days, that part of the brain will shrink back to what it was like before. This is a big part of exercise. It's not just that your muscles get better, but that your brain gets better. And that is neuroplasticity. So neuroplasticity, or the concept that your brain improves with practice, there's several rules. And I want to share with you what to me are the 5 most important rules for MS patients. The first is you get good at what you practice, meaning that if you want to get better at walking, you have to practice walking. If your walking is getting bad and you practice, you go to therapy and you work on a bicycle or get into a pool, your walking is probably not going to improve. Your biking and working in a pool will get better, but if you don't practice what you want to get better at, you're probably not going to get better at it. Similarly, you get bad at what you don't practice. In the same way, the guitar player's guitar playing got worse after not practicing for 1,000 days. A lot of the difficulty you have with walking, for example, if you walk less because of MS, occurs not just because of the disease, but because of the lack of practice. You get good at what you practice, and you get bad at what you don't practice. The next thing is, and this is really important for MS, is the concept of dosage or volume. You need a certain amount of practice, a certain volume of dosage or practice to get the best response. So the guitar player, example, the guy was practicing 5 hours a day and he got quite a bit better. If he only practiced for 5 seconds a day, he probably wouldn't get better at all. So there's a certain dosage that's needed to make changes, and this is very important for people with MS. Okay? What's more, you need to practice at a certain intensity. You can't practice gently. You have to push yourself, what my patients call the yuck factor. The practice has to be enough so that it's a little bit challenging for you. If it's too gentle, you just don't get that much of an improvement. And the last rule that I want to bring up is the rule of salience, meaning the practice has to be meaningful to you. You have to understand what you're doing. You have to know why you're doing it. You have to know what's the expected outcome, and why you're practicing this is going to have a good outcome for you in the end. The patient I just saw, a young man with MS, and he really wanted to get back to playing soccer. So I could have done strengthening with him or stretching or whatever, but what I really made him do was really work on kicking a soccer ball with his weak leg, or balancing on his weak leg while kicking the ball with the other leg. So the practice was meaningful to him. He said he can't wait to start practicing and doing his work. You get good at what you practice, and you get bad at what you don't practice. If you practice walking, you will get better at walking. And the more you practice walking, the better you're going to get at walking. If you don't practice walking, don't expect your walking to improve. Exercise must be what I call task specific. You need to practice the things that, with the task, that you want to improve in. And this is not just for persons who are walking, but it's also for bed mobility, for transfers, for moving in a wheelchair. Anything that you want to get better at, you have to practice at a certain dosage and intensity to improve. Also, you get bad at what you don't practice, okay? And the reason why this is so important is it's shown me that a lot of the disability that is seen in persons with MS may not be due to the disease itself, but instead is due to the fact that the person has stopped doing the movement. Okay? The young man who I saw earlier today, his right arm had gotten so weak and so tight, but there really wasn't that much disease. It was simply that he'd stopped using it and hadn't used it for years. And this suggests that a considerable amount of the disability that's seen in persons with MS is learned, is acquired, and is not a result of the disease itself. And this is good news. Okay? It means when patients improve, it's not just that the MS is getting better, it's just that you've been practicing things that you haven't practiced in a while. When I see a patient and they start getting better within a week or two of starting physical therapy, I think I'm a pretty good PT, but I don't think it's because I've fixed their nervous system so fast. It's just that they've started practicing things that they haven't practiced in a long time. Okay. As I said before, for medicine to be effective, it has to be performed at a sufficient dosage. Therefore, for exercise to be effective, it must be performed at a sufficient dosage. For those of you, and I'm assuming most of you are on disease-modifying therapy, you have to take a very specific amount of the drug at a very specific time. If you took a fraction of that less frequently, you wouldn't expect it to work. Exercise is the same. The exercise must be done at a sufficient dosage, and it must be done with some intensity. But dosage with MS has a very specific issue, and that has to do with the two most common problems with MS, the problems of fatigue and thermosensitivity. And what I'm sure all of you know, especially in this hot summer we're having, if MS core temperature increases, then conduction through the demyelinated nerves decreases, and this results in an increase in symptoms and a decreased ability to exercise at a sufficient dosage. So the problem is that I want persons with MS to exercise, but exercise causes an increase in core temperature, so they can't exercise. So how can persons with MS exercise at a sufficient dosage and intensity if the exercise itself raises their core temperature so much so they can't exercise at sufficient dosage and intensity? And this is the paradox of exercise in MS. And I remember very clearly a patient of mine yelling at me with such frustration, getting better is too hard. It makes me so tired. Okay? So how do we improve the mobility of persons with MS with exercise if exercises raises core temperature, which makes mobility exercises difficult? Okay. So how can science help us? Okay. What does science tell us about MS and exercise and the problems of fatigue and thermosensitivity? Okay. So we're going to use science. So what are the problems here? We need persons with MS need exercise to improve. Exercise raises core temperature. Core temperature worsens MS symptoms. So I will hypothesize then that if we can find a way to lower the core temperature, that will allow persons with MS to exercise more and get that dosage. So then my research question then becomes, how can we lower core temperature of persons with MS while exercising? And the answer, I think many of you know, is by using some type of cooling vest. Now, the first thing I got to say is that the MS Foundation folks are some of my MS heroes because they run this amazing program to get cooling vests to people with MS, and you all should be taking advantage of it. And you're going to see from my research why. Now, the other thing is, I used to have some of my patients saying, I don't want to wear cooling vests because I'm very fashion conscious and these don't look very, fashionable to me. And what I noticed when I was preparing this talk is, well, the guy in the front, in the middle, looks a little bit nerdy, but the two on the side look kind of cool. So if you're looking for fashionable vests, they're out there. Although maybe this one looks like the guy's hair fell out after putting on the vest. I'm not sure. Okay, so what about cooling vests? Well, we just completed a study at Hunter College. I'm very honored to be a tenured professor of physical therapy at Hunter College, and I get to work with these incredible doctoral students who were very excited about the study. And I do want to say that this study was funded by the MS Foundation, which I'm very grateful. We did a very simple study. We took persons with MS, they had to all be ambulatory, and we put them into one of two conditions. First condition was called pre-cooled. All that means is they come in, we put a cooling vest on them, and they would wear it for 30 minutes, really cooled them off. Then we took off the vest, and then we did what's called a 6-minute walk test. And that's exactly what it sounds like. They have to walk as far and as fast as they can for 6 minutes. Then a week later, they'd come back and do the same thing without the cooling vest. They would sit for 30 minutes and then do another 6-minute walk as fast as they could. And then we compared their performance on the two walks. What did we find? Well, first of all, you can see that in the cooled condition, I'm going to see if I can get a pointer here. Remember how to do this. Here we go. Let's try and annotate. You can see that in the cooled condition, subjects walked about on the average 797 feet. In the uncooled condition, about 50 feet less. Now this was pretty impressive. There was no extra training, there was no extra anything. Just with this cooling vest, they walked farther. What was more interesting about that is they all thought they'd walk slower because they said the vest made them feel heavier. But they all walked faster. Some by a few feet, some by well over 100 feet. But everybody walked faster, without exception. But here's where it gets interesting. So we timed them, we measured how fast they walked over the first 3 minutes. In the cooled condition, about 401 feet, and in the uncooled condition, not that different, about 394 feet. So not a big difference. Look what happened in the last 3 minutes. In the cooled condition, they still didn't slow down that much, about 19 feet less. But in the uncooled condition, they slowed down a lot by over 100 feet. Okay? So the cooling vest kept them going at that pace for a longer period of time. So what happened here? What happened here is I have a screen freeze. Oh, dear me.
You might want to try ending your share
Okay,
and then resharing.
let's give that a try. Excuse me, everybody. I'm going to stop the share. Okay. And now let's try the share again. Okay, looks like that did it. Thank you, Dr. Minnis. Okay, so after you do a study like this, you spend a lot of time talking with the persons who you conduct the study with, and we try to figure out what happened. And the first thing we were able to conclude that the improvement was almost entirely due to the not slowing down in the second half. And we hypothesized that the cooling prevented the core temperature rise, which occurred in the uncooled condition. So we can hypothesize with some confidence that cooling improved the walking by limiting the effects of the thermosensitivity. So we just finished this study a little while ago. We've been presenting it at conferences, and we're going to write up the study over the summer and get it published. And thanks again to the MS Foundation for funding us for this study. But this is something that all persons with MS can do. It seems to help everybody. I have one patient who's actually, even with MS, is a very serious bike rider, and she wears a cooling vest all the time. She carries extra ice packs with her so she can switch them out. Simple thing to do, good response, easy. Okay, the next thing I want to do is talk about a technique that we've been studying at Hunter for a while that seems to help exercise with MS, called intermittent walking or intermittent exercise. And all that really is interspersing periods of walking or any type of exercise with periods of recovery. Now, most walking programs, most exercise programs in MS are continuous. Go, 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 go. Don't take a break. You can't take breaks. I would suggest that this is a bad idea for persons with MS. The longer you walk or the longer you exercise for without a break, the higher your core temperature gets. So we ask the question then, will taking rest breaks result in a bit of a lowering of the core temperature? I will hypothesize that persons with MS who take rest breaks or who walk intermittently will be able to walk longer distances than those who do not take rest breaks, or those who walk continuously. Okay, so we performed several studies on this at Hunter. In the first, we simply looked at a 6-minute walk for persons with MS, and we had them either walk 6 minutes without a break as fast as they could, or walk for 2 minutes, sit and rest for 2 minutes. Walk for 2 minutes, sit and rest. Walk for 2, sit and rest. Okay? When the persons walked intermittently, they walked well over 100 feet further, but they said they didn't feel as tired. So they walked longer distance with less subjective feelings of fatigue. And this suggests a greater volume of walking can be achieved by persons with MS if rest breaks are given. Here's the graph for that study. If you look at the white bars as opposed to the dark bars, the white bars is when the subjects walk continuously. And you see they go down, 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 down. When they walked intermittently, they actually went up and then stabilized. Okay. And there was nothing fancy here, same patients in both conditions, same area, just in one they took breaks and in one they did not. And simply by taking a break, they walked over 100 feet further. So this seems to solve the volume problem. Okay, but we looked at it a little bit more. Huh. Okay. Sorry about this. So the annotating things doesn't seem to be working, but I'll keep working with it. In the next study, we decided to push things a little bit farther. We took patients with MS and simply said, walk as far as you can. Walk until you feel like you can't go any further, or we'll stop you when it looks like you're really having trouble walking. So, and we had them do it at a steady speed on a treadmill. And they had to do it in two conditions, either walking without a break or, excuse me, they would walk for 30 seconds, rest for 30 seconds, walk for 30 seconds, rest for 30 seconds. But in each case, the subjects were told, walk until you can't go anymore. We hypothesized that the persons with MS would walk for a longer period of time if they walked intermittently, because the rest breaks would keep the core temperature from rising too rapidly. And here are the results. You can see here that in the intermittent condition, they walked 1,575 feet on the average. In the continuous condition, over 500 feet less. Okay. The persons with MS walked further before they ran out of gas, intermittently by taking breaks, than by walking continuously. So once again, this seems to show clearly that by taking breaks, you end up being able to walk a longer distance. Okay, so what's next? Close out of this. So in the first two studies, we looked at a single bout of exercise. Now we thought we'd look at what if somebody, instead of walking a single time, if we had them trained. So we trained them, patients, to walk either intermittently or continuously twice a week for 6 weeks. The intermittent training was simply walk 2 minutes on, 2 minutes rest, 2 minutes on, 2 minutes rest, 2 minutes on for twice a week for 6 weeks. The continuous, we just simply had them walk as far as they could for 6 minutes twice a week. Okay, and this is what we just said. So the total amount of walking in each case was the same. Both conditions, they walked for 6 minutes as hard as they could, but in the intermittent training, they rested every 2 minutes, and in the continuous training, they did not rest at all. Total amount is the same. And what do we find? Okay, well, you can see here in the blue, which is the continuous, the actual distance walked after the training went down. Okay, went from an average of 1,278 feet to 1,219 feet. Whereas in the intermittent, it jumped by almost 150 feet, from 1,150 to 1,204. Okay, so once again, by training intermittently, they were able to walk longer distances. Okay, so in the next study, we decided to push it even further. Now, most of the walking that's done in walking training that's done in multiple sclerosis is very much based on endurance, on walking relatively slowly, but for long periods of time, whether it's done intermittently or continuous. However, in the last few years, there's been some research that's shown that to improve walking endurance, but patients who walked very, very fast improved not just their endurance, but their balance and their symmetry, meaning their left side looked like their right side when they walked. This was done successfully in persons with stroke and with spinal cord injury. Now, I know that walking at faster paces is rarely done in MS, okay? And as a result, persons with MS are rarely able to walk fast. And this is pretty important, especially where I live in the city, where there are very, very long streets to cross, and the traffic is coming pretty aggressively, and the person has to be able to walk fast to get across the street in time. Now, there's a type of training that some of you may have heard of called high intensity interval training, or HIIT, which simply is doing some type of exercise very intensively for very short amounts of time with long recovery. We tried that in MS. Okay? So we asked our subjects to walk for 20 seconds as fast as they could. They were guarded by a physical therapist for the whole time. They did 6 to 12 repetitions of this with 2 to 3 minutes recovery. So 20 seconds on, 2 to 3 minutes off, but the on time is all out. They did that twice a week for 6 weeks. The outcome measures were the 25-foot walk test, which is simply how fast can you walk for a short period of time. The 6-minute walk test, which is how good is your endurance. And the mini best test, which is the balance test. Okay. Here we go. Okay. So we call this speed intensive gait training, or SIGT. We measured our subjects 6-minute walks before and after the training. On the average, our subjects walked 940 feet in 6 minutes before the test and improved after the training to 1,139 feet, or an improvement of close to 200 feet. Their short walk speed improved as well, from 10.5 seconds to 8.5 seconds. And surprisingly, their balance improved, particularly their walking balance. On the test that they used, there is a section of the test where they rate you on 8 different balance tests. And we found that before the speed intensive gait training, the subject scored a 4.3, but after they improved to a 5.5. Okay? So in this training, the subjects trained very, very fast for very short distances, twice a week for 8 weeks. And this relatively small amount of training, so the most anyone ever did the fast walking was, say, 20 seconds 12 times, or 240 seconds, or 4 minutes of hard training. Okay? And this led to improvements in their endurance, improvements in their speed, and improvements in their balance. The faster training didn't just improve their endurance, but their motor control. They were more symmetrical, they had more control of their body. But what still always strikes me about this is these people made these tremendous changes literally by training 4 minutes a day, by doing 4 hard minutes of walking 2 or 3 times a week for a few weeks. Not a lot of training, big improvement. It's not a lot, but it had to be very hard, very intense. Okay, so now that I've reviewed my research, I want to make a few generalities here. I want to strongly differentiate between two different types of research. There's research that's meant for fitness or wellness, and there's task-specific weakness. So fitness exercises are things to strengthen your cardiovascular system, to improve the strength of your muscles, to improve the flexibility of your joints. And this is what a lot of people think of when they think of exercise. And there's really nothing wrong with that, but it will not give the improvements in mobility. I want to tell a story some of you may have heard me tell before. A couple years back, a patient came to see me, middle-aged man, and he actually looked quite good, quite strong, quite fit. Was having trouble walking though. And when I saw him, he looked a little bit upset with me. I asked him how he was, and he said, Herb, I got to tell you, I've heard your talks about exercise and mobility. Hasn't helped me at all. I'm still getting worse, even though I exercise all the time. I said, well, what kind of exercise do you do? I said, well, I do weight training every day. I do push-ups every day. I do sit-ups every day. I ride a stationary bike every day. I go swimming a few times a week, but I still am having a lot of trouble walking. I fall when I walk, no matter how hard I exercise. And I said, the problem is not that you're not exercising enough. It's that you're doing the wrong exercise. What this man had was foot drop. He had foot drop in both of his ankles, but the exercises he was doing did not address them. He was very fit, okay? He was very strong. He had, a flat stomach and big shoulders and, good heart rate and blood pressure. But he wasn't practicing the things that he needed to practice. He wasn't trying to stretch out the 2 foot drops that he had. He was just doing lots of weight training and bike riding. So he was fit, but he was not functional. Okay. So what then is the goal of exercise for persons with MS? What do you want out of your exercise? What do you want your exercise to accomplish? Whenever I see a new patient, I ask them right away, what do you want? What can I do for you? What is your ultimate goal here? And how can we use exercise to help you get this goal? So I was saying the young man who I saw this morning, the things that he really wants to do is be able to play soccer, play basketball, and go skateboarding. And I got to admit, the skateboarding gives me a little bit of a heart attack, but these are the things that's driving him. I said, okay, so if you want to do these things, you're going to have to play soccer and you're going to have to go skateboarding. These are the things that if he wants to get better, he'll have to practice. And this is the same for anyone with MS. You need to practice what you want to get good at and stop practicing the things you don't want to get good at. So the goal of exercise in MS, if you want to improve walking or balance, you have to practice balance and walking. Practicing in cycling will lead to improvements. Practice in water aerobics will lead to improvements. They will just not lead to improvements in function. You can, by doing fitness exercises, get fitter, but not necessarily improve function. However, if you work on function, you will functionally improve and you'll get fitter. Okay, so let me summarize here. There's lots of good, strong scientific evidence supporting not just the safety of exercise for persons with MS, but the efficacy of it. Does it work? Yes, it works. Persons with MS who exercise are going to do better than those who don't. And that's pretty strong evidence that there's something that's neuroprotective about exercise. However, any type of exercise is better than doing nothing at all. So if the difference is between, lying down in bed all day and riding a stationary bike for a few minutes, you're much better off riding the bike. But you're not going to make the same functional improvements. And finally, to improve at anything, to improve in any type of exercise, you need to practice the thing you want to improve in. If you want to get better at any task, that's the task you need to practice. Okay. So final slide, leaving us time for questions. There are unique aspects of MS which make exercise hard. MS is not the same as stroke. It's not the same as spinal cord. Because of fatigue and thermosensitivity, exercise is especially problematic for MS. Thermosensitivity and fatigue limit the dosage of exercise that can be performed with MS. Exercise can get people with MS better, but the fatigue and thermosensitivity prevents you from achieving that dosage. Cooling is one of the easiest and most effective things you could do to help this. Using intermittent exercise can really help reverse a lot of the disability and sedentarism that persons with MS struggle with. The use of fast walking, and I'm telling all my patients now, try a few times a week to do a couple short, fast walks. How fast? Just faster than you normally do, and make that a regular part of your program. And finally, task-specific training provides you the best outcomes. If you want to get better at a task, you're going to get better if you practice that task. If you practice an alternative exercise, you'll get better at that exercise, but not at the task. So my final comment before I open up for questions is the science is very clear that exercise can improve the mobility of persons with MS, but you have to really do it in a very specific way. And I've tried to give you in a few brief slides today what those specific things are. Be cool, take breaks, task-specific training. Okay, with that, we have about 10 minutes left. I'm going to open it up for questions, and I'll let Casey be the moderator.
All right, thank
Any
you.
questions at all?
To our audience, if you would like to ask a question and you are on the Zoom, you can use the Q&A button to ask your question, or you can use the raise hand button. The raise hand button will allow us to bring you on the line to ask your question live. So for either of those, just touch or click your screen and you'll find Q&A and raise hand on your toolbar. We'll also try to get to any questions that come in on the Facebook Live. You can leave those questions and comments.
Right, so I see 3 questions on
Q&A.
Q&A. Well, I'm going to get to those right away. Is this on Q&A or chat? Doesn't matter. I broke a bone in my foot on my weak leg, oof, and had to wear a boot for 6 weeks instead of my AFO. Now you can't walk as well as you used to before breaking your bone. Go back to PT, absolutely. If you broke a bone in your foot, you probably lost flexibility and strength in that foot. You should absolutely get to your PT as fast as possible because you need to get the strength and flexibility back in that foot. Next question is one of my favorite questions of all time. Can foot drop be reversed or improved? Absolutely. This is 50% of what I do with my patients. But the thing is, the dosage problem still needs to be addressed. So a lot of times someone will come to me and say, I tried stretching, it didn't help. I said, how much do you stretch? And they say, oh, I stretch out my tight foot drop for about 30 seconds a day, 2 or 3 times a week. This is the dosage problem. You're not stretching enough. It should be more like 5 to 10 minutes a couple times a day if you want to make an improvement. Otherwise, your foot is plantiflex for 23 hours and 59 minutes a day, and the stretching is not going to be sufficient. So you will need to stretch your calf muscles out to reverse the foot drop, and you need to do it for a long enough period of time. Next, can you get copies of the slides? Absolutely. Casey, will you guys take care of that? I've shared my slides with you. Absolutely.
Yes, we are more than happy to do that. Anyone who wants a copy of the slides can reply to your registration email. That'll come to me and I'll be happy to share that with you. And also the entire presentation will be available on the Foundation's Facebook and YouTube pages.
Okay. Elizabeth Rash just asked, what stretches for foot drop? The simplest stretch is called a runner's stretch, where you, in standing, you put the tight foot about 6 to 12 inches behind the other foot. You keep the foot behind you with the knee straight. You put your hands on a wall for support, and you bend the left knee. And you'll start feeling a pulling in the left calf. And what I can do, Casey, if you want, is go to your Facebook page and put in some photographs for stretching, okay?
That would be terrific.
I will absolutely do that. Okay. All right, we have some hands raised, I think.
Let's see, we do indeed. We have Karen.
My PT says I have too many lesions to functionally improve my foot drop. PT says, since I can't lift up my big toe, I will always have foot drop and a limp. Oh, that's unfortunate that the person said that. Always a foot drop and a limp. PT says neuroplasticity won't work due to lesions. I don't want to go against what your PT says, but that has not been my opinion. That has not been my experience. The young man I'm working with has had a foot drop for about 17 years, and he's already showing improvements in 2 weeks. But you gotta stretch the heck out of it. There's something called a night splint, okay, which holds your foot in a stretched position. Okay, and you wear it for hours at a time rather than just doing the runner stretch that I told you about. Myrna Silva, you may want to ask your PT, have they worked with people with MS before, or people with foot drop before? Because what the PT is saying is absolutely not my experience. And if you want to ask the PT to reach out to me, I'd be more than happy to talk to them, because this is my bread and butter. This is what I do all day. Let's see.
We have Karen on the line who has a question.
Yes, hi, doctor. I guess this is the foot drop day, because I have a foot drop in my right foot. I was just diagnosed last year. I wouldn't say that it's severe. I really appreciate the recommendations you're giving about interval training and intensity, and I'm going to try all of those. Often, though, I start to get pain in my right hip flexor after walking for some period of time. And I'm always concerned, is that an orthopedic issue that's developed because I'm not walking properly, or is that part of an MS symptom?
Is your right leg the weaker leg?
Correct.
Well, it's I'm almost certain that it's orthopedic. And the question is, are you overusing that muscle, or is that muscle tight? Do you know how, go ahead, I'm sorry.
Probably both.
Okay, well, do you know how to do a hip flexor stretch?
I do, from a Pilates standpoint of.
Okay, so how about really working on your hip flexors to stretch out the hip flexors before and after you do a walk?
Okay, good to know. I look forward to seeing the slides too that you're going to post up in regards to foot drop.
I could probably post up more. I didn't realize I could use I could take advantage of the kindness of the MSF to post my slides, but that would be awesome.
Okay, great. Thank you for the advice.
My pleasure. Okay, Karen Weiss. Let's go to Q&A.
Okay. Thank you for your question there, Karen. And now we have one more question in chat that says, if I wear a brace, CAFO, should I exercise with or without the brace?
Ooh, it depends. Depends on what exercise you're going to do. Can you walk? Do you need the CAFO to walk?
Let's see. I believe the answer popped in yes, needs the KFO to walk.
So if you need the KFO to walk, then you should do the KFO. But for stretching, you should probably take the brace off. For stretching and strengthening, take the brace off. But for walking, leave the brace on.
And one final question we have in chat says, I have MS and Ehlers-Danlos syndrome, which complicates my exercise and stretching. Currently going on trail walks with husband, but difficulty with recovery after exercise. What would you recommend?
Ooh, yeah, that's a tough one. Ehlers-Danlos and MS is a tough combination. So let's see if I can understand what's going on here. So the Ehlers-Danlos is probably not the cause of the spasms and tingling, but is probably making the spasms and tingling worse. Do you try stretching before and after the walk, particularly the spasms in the legs? Does the stretching help?
And Melanie says, yes, she's tried. No, it hasn't helped.
Okay, are you on any medication for the spasms, like baclofen or gabapentin? You're on both. Okay. Does cooling help you? Have you tried cooling before walking? Okay. Not your feet, but what about, so here's an idea to try. There's something then, because obviously that's going to be a problem with Ehlers-Danlos. Are your feet ice cold or your whole body? Okay, so we're going to, here's something that there's some really interesting research, science about, and it's something called reflex cooling. Okay, so my guess would be your core temperature is still rising, which is leading to the fatigue, but you can't cool off your feet because of the coldness in your feet. So you can try something called reflex cooling, which means you can wear a cooling, you can get cooling wraps for your wrists or around your neck. And this actually will reflexively cool off the rest of your body. Okay? So you may want to give that a try. It's a difficult combination, the Ehlers-Danlos plus MS. And the cold is probably a part of it. One last question for you. I know we're going over, but this is always the danger when you invite me to talk. I don't shut up.
We're happy to have you for as long as you want to talk, Dr. Gay.
I'm good. No, I'm good. I want to help Melanie. You wear a cooling cloth while walking. Okay, this is going to sound a little contradictory, but have you ever tried warming up your feet before you walk? Because I'm thinking I had another patient, she didn't have Ehlers-Danlos, but she had a terrible problem with cold feet and really made her walking painful. And what she did was before a walk, even in warm weather, did something to warm her feet up. She either used a foot warmer or used a warming blanket, and that relaxed her feet before she walked and made the walking much easier. Have you ever tried anything like that? Okay, it's interesting because she said that and I wasn't quite sure what to do for her. And so I said, okay, let's try this. And I had her take off her shoes and socks and her feet were ice cold. And I just literally massaged the heck out of her feet for 10 or 15 minutes. And she jumped up and walked on the treadmill for about 15 minutes. It didn't last, but she said, I can't have you massaging my feet every day, but maybe I can train my husband to do this. So now it's between you and your husband. But I have a feeling the spasms may be coming from this cold. So why don't you give that a try? Just have your husband give you a massage, or just put some heating blankets on your feet for 10 or 15 minutes. Not your whole body, just your feet. Okay, give that a shot.
Dr. Karpatkin, if you have a few extra minutes, we do
Of
have
course.
two more
No.
questions
Let
come
him-
up
let
in
him-
Q&A and
Let
one
him
more
come.
raised
No.
hand.
Keep it
Okay,
going.
so let's bring Susan on the line to ask her question. Susan, go ahead.
Okay. Let's see,
Hi.
Susan, I use a walker.
Yes, I am.
Oh, go ahead, Susan.
Yeah, I use a walker and I've used it for the past since 2014. And there's no way that I can walk without using the walker. So I use my arms and my legs to walk. But I also have arthritis in my arms and my shoulders. Is there anything that I can do? Because I love to walk. Is there anything I
Yeah.
can do to walk
No.
to avoid the no?
Definitely got to keep you walking. No. I didn't say no. Oh gosh.
No, okay, good.
I don't say no. So the walker that you use, what type of a walker is it?
It's one without the wheel. What kind of walker do I have, Glenn?
Is it a rolling walker or a standing?
No, I can't use a rolling walker because it will escape from me, out from
Okay.
under me.
Okay. Have you ever heard of so you have to pick the walker up and put it down?
Yes.
No.
Okay. And probably every time you put it down, it makes your shoulders hurt, right?
I'm so sorry. What did you say?
I would guess that every time you put the walker up and put it down, that makes your shoulders hurt.
Well, I'm so sorry. I've got 4 wheels on the walker. So it's the old-fashioned kind, I guess you can say. So I push it.
So you do have a rolling walker.
I don't have a rollator.
I understand that. So it's a four-wheel. It's a 4-wheel walker.
Correct.
Okay, good. Now we work that out. And do you have pain in your arms from the arthritis when you walk, or before you walk, or during or after?
Just when I walk.
Okay. Has the walker been measured for you?
No.
So when you walk and you're standing in the walker, are your elbows straight or slightly bent or very bent?
Slightly bent.
Okay. So the first thing is to make sure it's well measured, and a physical therapist can help you with that. The second thing is how are your hands?
I've got arthritis in my hands too.
Okay, so the next thing I would recommend is you put some type of a soft foam grip where you hold the walker so that it cushions your hands and it dampens the forces going into your shoulders. Now, do you do any exercise for your arms, for your shoulders?
I do not, no.
Okay, time to start. Okay, because the problem with arthritis, one of the worst things you could do for arthritis is not move your shoulders or not move the arthritic point. So you need to start doing some type of exercise just to move your shoulders around.
Okay.
And a PT can show you that. But the problem with using your arms a lot when you walk is your arms are kind of locked in place. And the more you move your arms at this point, the better. So I think it's super important that you keep walking. And to do that, you have to take better care of your shoulders. And
Okay.
so maybe seeing a PT for your shoulder pain would be a really good idea.
Okay, thank you.
Thank you.
Thanks for your question, Susan. And we have one more in chat from Michael.
Okay, Michael. My left side is my weak side. You have a 40-degree hyperextension. Do you mean your, Michael, does that mean your knee is like double jointed 40 degrees? Is that correct? Oh
Yes.
boy. So are you still walking? Good. So here's the problem, pal. If you get a knee replacement, you're going to be, a knee replacement is a big, painful, bloody surgery. It's a successful surgery, but my big worry, you're the guy using the KAFO, got it. So the KAFO keeps your knee from snapping back, is that correct? Yeah. My worry is if you get the knee replacement, you're going to be laid up for a long period of time, and you might lose the ability to walk that you already have. How much are you walking now, Michael? Got to be a little more specific than that. Is it like, can you walk for 10 feet, 20 feet, 30 feet? Okay, so have you seen, are you in pain because of the hyperextension?
I'm going to go ahead and bring Michael on the line so he can
Yeah.
answer you directly.
Taking time. That's good. Save us some time here.
Michael, can you?
Yeah, am I there?
There
Hey, Michael,
you go.
how are you?
I'm good.
All right, so Michael, do you have pain in that knee?
I actually don't. I don't have any pain in my knee. It's ironic. I mean, it goes
So-
back about 40 degrees because the brace, the guy who did the brace measured it. But without it, I have to use a rollator all the time around the house. And when I leave the house, I use a cane and the brace. And the only thing that worries me about replacing a knee is because I have a lot of loss. Like, you know, I can't raise my foot. I have the dorsiflex. None of it works. So I'm more
Yeah.
concerned with being able to
So-
build that muscle back around the knee.
The knee replacement is not going to reduce the dorsiflexion. It's not reduce the dorsiflexion issue. Has a surgeon advised you to get a knee replacement?
Well, I did. I talked to a surgeon once, and he was very, he was very pro. Get your knee. Yeah, you definitely need, this knee is shot. You need a knee replacement. And then when I went in and talked to him about my MS and what I could and could not do and what muscles were firing, he kind of said, yeah, that's going to be a problem.
Right, because the recovery from a knee replacement is can be quite difficult. And if you're walking 30 to 40 feet now, do you walk that distance every day?
On and off. I mean, if I leave, I still go out. I can drive because it only affects my left side. So my right side works, so I can still drive a car. But when I leave the house, without having to use a rollator, I'm on the cane and the brace. And I still, I mean, I get around if I can go anywhere I need to. Just went to Maine for a week
I'm
vacation.
afraid that although the knee replacement can get rid of that hyperextension, it may actually keep you from walking while you're recovering from it. And you may be worse off afterwards.
Well, that's what I'm worried about. More worried about
And
worse.
The
I mean,
fact, usually they give a primary indication for a knee replacement is pain. And if you're not in pain and you're still able to walk as much as you do, it may not be a great idea for you. For the knee
Okay.
replacement to be a option worth considering, we should have some pretty good confidence that after the knee replacement, you'll be in better shape than you are right now. And I'm not confident about that.
Yeah, I don't have any. It's amazingly, I have no pain in that knee when it's hyperextended.
Yeah,
If I stand, when I stand for long periods, it's always hyperextended because I just it'll pop on its own.
yeah,
So that the KFO helps keep it from bending, but it also helps the knee from buckling inward.
yeah.
It's losing strength.
I mean, to be honest, if you were my patient, I'd be trying to increase the distance you were walking by using intermittent walking and having you to try and increase your overall distance. You're not experiencing pain. I mean, it's not that a 40-degree hyperextension is unimportant. I just don't think it's important enough to call for the drastic move of a total knee replacement.
Yeah, I appreciate that. I mean, it kind of makes me feel that's what I was kind of feeling. So it kind of reinforces that.
Yeah.
I'll hold off on that and exercise more.
Okay, well, good. All right. Anyone
So
else?
those are all the questions that I see.
Thank you.
Thank you. Best of luck.
All right. So just a few reminders to our audience that this conference has been recorded. It will be available on the msfocusradio.org page in audio. It will be available on YouTube in the coming days, and it is also available right now, if you missed any part of it, on Facebook on the Foundation's page. So if you'd like to see that or learn about future presentations, follow the Foundation on any of your social media. Our next teleconference will be Becoming the CEO of Your Wellness with the team from the MS Achievement Center, giving us the MS Achievement Center model for wellness, and that will be on July 26th at 6 p.m. Eastern. So for now, our sincere thanks to all of you who attended and who participated, and especially to you, Dr. Karpatkin, for such great information and for all the research that you've done to benefit the MS community. It's such a wonderful thing. Thank you.
Well, thank you for your support. It means a lot. Great.
All right, everyone. So that's our program for today. Again, thank you for being with us and have a good one.